Wellbeing Board on this date. It's the 8th of April. I'm getting carried away. One day near an election. So off we go. Apologies for absence. Anybody?
Chair, I have apologies from Ralph Firth, Jim Mackey, Claire Riley, Councillor Sanderson and Graham Sayers.
Right. Any from the floor? I can't see anybody. I'll bash straight on. Minutes. We have the minutes of the previous meeting held on last month.
Chair, can I just say they're going to the June meeting because they weren't ready in time?
Yes, that's why I'm looking for them and can't find them. Right, so they're going to the June meeting. Right. Item 3, disclosure of interest. Any member or officer or anybody wishes to disclose anything. I cannot see any hands at all. So I'll move on. Items for discussion. And we go to the update on the Northumberland COVID-19 outbreak prevention and control plan. Over to you, Liz Morgan.
Thank you. Okay, so can everybody see that?
Yes.
Okay, brilliant. Okay, so I'll just start by looking at what's happening nationally, and what this graph very clearly shows is that there has been a sort of plateauing of cases. So the rate of decrease has dropped off, and the sort of various regions are converging at a rate which is significantly lower than it has been. But although the rate of decrease has slowed, we are still seeing a decrease in the number of people being admitted to hospital, the number of people in hospital, and deaths are continuing to fall, which I think we can attribute to the vaccination programme. From a regional perspective, or certainly from an LA7 perspective, a very similar picture. So again, you can see that cases have levelled off. But I suppose what it's worth mentioning here is that at these very low levels, any sort of blip within a local authority in terms of an increase in cases is often attributed to something specific. So it might be an outbreak in a particular setting or an outbreak in a particular community, but it's actually much easier to identify what that increase is attributable to. And this is the Northumberland view as of a couple of days ago. Case rates really much lower than they have been probably since the beginning of September. We're literally only seeing just more than a handful of cases a day at the moment. But of course, we need to put that into the context of schools having been closed since the end of March, and really some significant restrictions still in place. We're not really certain what the impact of school opening has been, because obviously they were only open for sort of 3 weeks before the Easter break. But obviously there will be an impact when schools return on Monday, and of course that coincides with the opening of non-essential retail. So I think we can probably expect cases to bounce up again, but we just sort of have to see what that looks like in terms of our local figures. And also of note here is that we've only got 2 wards with more than 5 cases. So all in all, you know, a pretty positive picture. This heat map looks at case rates in different age groups. So timeline is along the bottom, and then up the side we have the different age groups with all ages at the top. And what this clearly shows is that we had a real sort of blip in primary school age children a couple of weeks ago, and a lot of that was attributable to clusters of cases in small numbers of particular schools. But I think the other notable thing is the real reduction in case rates in people over the age of 60. I think, you know, it is obviously difficult to disentangle the impact that the restrictions have had rather than the impact of vaccination. But I think what we are seeing is certainly a significant contribution from vaccination in terms of case rates. And of course, we do have some real-time data which has demonstrated that in those individuals who've been vaccinated, the risk of being admitted and the risk of going into ITU is significantly lower. Looking at excess deaths then, so this is looking at deaths reported up to the middle of March, and what this looks at is the deaths over the last 12 months compared to the average number of deaths over the period 2015 to 2019. So the red lines there, the red bits of the graph are where COVID-19 has been mentioned on the death certificate, and the grey lines are all of the deaths where COVID hasn't been mentioned. And you can clearly see that the deaths really ballooned during the peak last year. So excess deaths were really quite significant, but actually not quite so large during the increase in cases that we saw at the end of last year and the beginning of this year. And what we have seen in the last 3 weeks of reporting, which is sort of largely end of February up to the middle of March, is that actually excess deaths is that they're actually significantly lower than they have been. And I think there are probably a number of reasons for that, but some of that might be attributed to some very frail people who have unfortunately died earlier because of coronavirus. So we see that sort of dip after a peak. And then in terms of outbreaks and incidents, I suppose the incident that has had the biggest impact on us locally is the laboratory processing area that was reported for the northeast. So across the northeast, that affected 850 cases from symptomatic or largely symptomatic PCR tests taken over a number of days in March, and it primarily affected the northeast and Yorkshire, and meant that those individuals had their samples reported as positive instead of being reported as void. There were quite a few cases in Northumberland. Some of those cases affected some of our care homes. That caused quite a bit of work locally, but there was a national mechanism, or there was a mechanism put in place to ensure that all of those cases were notified either by email or by text and given appropriate advice around getting retested. From a care homes and care sector perspective, we are seeing really a significant reduction in the number of incidents. We've only had 2 new outbreaks in the last week, which is really good news. And of course, an outbreak could just be two 2 cases in the same setting, whereas it wasn't that many weeks ago when we were, seeing 15, 16 outbreaks at a time. And again, all the prisons across the northeast, including HMP Northumberland, that have had outbreaks, those outbreaks are settling. The prison, there has been a multidisciplinary outbreak control team meeting weekly for several months, actually, and we've done widespread testing across the prison, and really good to see that actually we had no new cases at the outbreak control meeting, which reported on Tuesday. So that also looks as though it's settling. And of course, the residents of HMP Northumberland will, are part of the vaccination programme, so that will provide them with additional protection. And unsurprisingly, in schools, we've literally had less than a handful of cases in the last week. Over the last couple of weeks, we've seen far fewer cases in secondary schools and primary schools, but I think that there is some confusion amongst parents about what tests to use when and in what age groups, because some of the information is a bit contradictory. So we're pulling together a sort of simple flow chart to try and support parents to navigate their way through the testing process. From a clinically extremely vulnerable perspective, so this is the shielding population. From 1st of April, that shielding population are subject to the national restrictions alongside the rest of the population. But we are still supporting those individuals and will continue to support those individuals for as long as necessary. And I think we need to be really sensitive to the fact that actually, the majority of this population will have been shielding at home since March of last year. And I think, anecdotally, a lot of them are actually really anxious about leaving home now. So I think certainly as an organisation, we're very sensitive to that in terms of having conversations about returning to work. And then there have been some testing policy changes. So the follow-up PCR test, which had been suspended, has now been reinstated. So irrespective of whether you have your lateral flow test done at home or in a supervised environment, you're encouraged to have a follow-up PCR test, and it's that PCR test that dictates the duty to self-isolate. And then from other developments and issues, we've had the announcement of the UK Health Security Agency. So this is the organisation that's going to take over the health protection roles of Public Health England, NHS Test and Trace and the Joint Biosecurity Centre. And that should be set up later in the year. And then we've already obviously had the publication of the regulations, which will dictate how we exit from the lockdown regulations. A lot of work being done locally to look at how we reopen, for instance, our tourist and visitor destinations, and also a lot of work to support businesses to make sure that they can reopen safely. From a testing perspective, you'll have seen the announcement that everyone will have access to twice weekly testing from the 9th of April. There are now a huge raft of testing opportunities from the asymptomatic community testing that supervised testing that we offer from some of our active Northumberland sites. to workplace testing, home testing, school testing, as long as the as well as the sort of existing national testing programs for care homes and domiciliary care providers. We've also been test driving a mobile asymptomatic lateral flow test supply pilot over the last couple of weeks, which I'm sure the Department of Health will evaluate, but the feedback certainly has been very positive to date. And then from a variants of concern point of view, I think that the main concern at the moment is about the South African variant, but it looks as though actually the proportion of cases, although with that I think there have been an additional 57 cases found across the UK, most of those have been found through the self-isolation process when people come into the country. So actually there isn't any evidence at the moment that those or that variant in particular is escalating anywhere outside those environments. And there is quite a robust process to follow up cases that we find in the community. And then just data from recent studies of interest. So the ONS survey, which is an ongoing survey, which sort of repeatedly tests tens of thousands of people in the community. The most recent month, or the most recent week, which is the week ending the 27th of March, suggests that about 1 in 370 people in the community in England tested positive for the SARS-CoV virus. That's down from 1 in 340 in the week before. There is some regional variation, and the regional variation seems to change from one report to the next. But in the most recent one, the highest rates were in, or the highest prevalence was in the North East and Yorkshire and Humber. Then we've also had some real-time data about the impact of the vaccine on transmission. That was done by Public Health Scotland and Glasgow University and a couple of other academic institutions. And that does suggest that vaccination, certainly of healthcare workers, was associated with a reduction in COVID-19 cases in household contacts. I think it was a reduction of about 30%, and that was after one vaccination. So, you know, we can probably anticipate that actually after 2, that effect might be greater. And then there's also been a report recently about rates of adherence to the UK's test, trace and isolate system. And I think it just reiterates what we already knew, really, was that actually people's actual adherence to test, trace and self-isolate behaviours is lower than their intention to carry out those behaviours. So although whilst people might intend to get themselves tested and self-isolate, the reality is that that doesn't happen as frequently as we would like. Still the case that actually the identification of COVID-19 symptoms is low. So we really need to keep pushing out those messages about what those symptoms are. And again, people's ability to self-isolate really has an impact on whether they get tested in the first place, but also whether they're able to self-isolate for the 10 days. And obviously there are a lot of people in our community who will really struggle to self-isolate at home for 10 days, particularly if they're in the sort of employment where they don't get paid or are relying on statutory benefits during that self-isolation period. So in terms of this sort of outbreak control plan itself, we've been doing local contact tracing since the beginning of February, and more of that contact tracing responsibility is being handed across to us as a local authority. So we were just restricted to doing the sort of straightforward cases, but actually now all cases which have not engaged with the test and trace process within a set period are passed across to us to manage as a local authority. So that includes contact tracing in some quite complex settings, but fortunately they're also quite few and far between. What we are looking at doing is moving into something called a local zero pilot. So actually that will then extend our contact tracing responsibility further to actually pick up all cases as soon as the positive result is received, rather than picking up cases that have failed to engage with test and trace within 24 hours. So that would effectively mean that we are taking on the tracing of contacts for all positive cases rather than the national test and trace team. There are quite a few local authorities in the northeast already doing this, so I think we're going to sort of sit back and learn from their experience before embarking on it ourselves. And of course there is a bit of workforce planning required, because we need to just have a really good understanding about what that burden of activity is going to look like, and what it might increase to in the future. And that's just a sort of a bit more detail about what the local zero pilot is, which I won't go into. And then asymptomatic testing, I talked a little bit about it. As I said, multiple access points now for lateral flow testing, and I think that's really undermined our ability to maintain the throughput of testing at our supervised sites, because I think it's easier for people to get tested at home. So we just need to think over the next few weeks about what our offer is going to be for asymptomatic testing, because clearly we don't want resources tied up in supervised asymptomatic testing if we're not getting people coming through. There's another 4 slides here about the wraparound groups, which I'm not going to go through in any detail, but I know that Andrew will send the slides around after the meeting. I think just to say that those wraparound groups are continuing to function extremely well, and obviously it's the workplace group at the moment, which is a hive of activity, as I said before, in terms of supporting businesses to open in a secure way. I think there's also quite a bit of work that we need to do around events, and that work's being done both locally and regionally. So I'll pass over to Richard or Rachel, who are going to talk about the vaccination programme.
Hi folks, can everybody hear me all right?
Yep.
Perfect. I was having some issues on my microphone before, which have been resolved, which is brilliant. I'll just share my screen for you all. So is everybody able to see the presentation?
Yes.
Yeah, perfect. So myself and Rachel are here today just to give you an update on the COVID vaccination programme, which obviously continues to be a rapidly evolving programme and situation. This is the slide we always start with when we do one of these presentations to either elected members or Health and Wellbeing Board, just to say that the really important message is that the NHS will get in touch with people when it's their turn to be vaccinated. In terms of where we're at with the priority groups, we're currently in the process of offering vaccinations to everybody within JCVI priority groups 1 to 9, and the next national target for delivery of vaccines is the 15th of April. Where we need to have offered a vaccination to everybody within cohorts 1 to 9. So we did 1 to 4 by the 15th of February, and since then we've been working down through the cohorts with the aim of having everybody over 50 and anybody under 50 who's eligible vaccinated by the 15th of April. In terms of the rollout in Northumberland itself, the figures here that I've included are those that are publicly available on the NHS England website and were published on the 1st of April. They come out every Thursday, so we'll get another set later this afternoon. But at the figures that were published last week, we'd vaccinated 166,219 people with a first dose, which is 59% of the eligible population. And then the second dose programme has been ramping up alongside that. We started second doses in March, and we've so far done 27,559 second doses. Of those first doses, we've vaccinated 84% of the total population over 50. So we're well on the way to hitting that target in terms of the 15th of April. From a care home perspective, we've vaccinated 96.4% of residents and 84.5% of staff with a first dose. So fantastic uptake there, and our teams that continue to visit care homes to do second doses for those residents and staff are making sure that anyone who didn't get a first dose the first time round for whatever reason are being offered a vaccine again. I think it's fair to say that there is a little bit of variation in the percentage of groups 1 to 9 that have been offered a vaccine across Northumberland, and the CCG in partnership with the System Vaccines Operations Centre have taken proactive steps to address that, which I'll discuss in a minute. But the key message for all residents of Northumberland is that there is enough vaccine supply to enable us to offer a vaccine to everybody within those first 9 groups. So just in terms of the supply, which has been a kind of constantly evolving picture, we're still under national command and control as far as the supply is concerned, and vaccine continues to be supplied via a push model. So ultimately what that means is we get what we're given based on the allocations that have been made to Northumberland based on our population within all the eligible groups. There's been, which has been well covered in the media, a significant reduction in the supply that's available nationally during April. That's expected to last for about 4 weeks, and as a result, the volume of vaccine available for first doses will be significantly constrained. So the priority will be second doses for those patients who were vaccinated in the early part of the programme, so those most vulnerable patients in cohorts 1 to 4. So just to give you an idea of what that looks like, we've included a bit of a table there. So during March, we had some of our biggest weeks so far in the vaccination programme, well over 20,000 doses. And then this week we have over 17,000 doses. We've actually increased our allocation this week by 6,000 doses, which we've brought into North Northumberland to make sure that they're able to offer a vaccine to as many people as possible in cohorts 1 to 9 who want to take that vaccine by the 15th of April. That variation that I mentioned before was something we've been aware of in the CCG for a long time and knew would be an impact. And would come as a result of people being sent national booking letters offering them to book at national vaccination centres, places like Centre for Life and the Nightingale, etc. We knew that residents in North Northumberland would find that the most inconvenient in terms of travel, and we've been lobbying for some time to get additional vaccine directed to the north to enable them to offer vaccine to more people locally. So it's good that we've been able to make some progress on that. And as I say, we've got 6,000 extra doses of vaccine that we've moved into North Northumberland over the last couple of days to help them hit that target. So lots of vaccination going on in the north this week. And then the 2 coming weeks, you'll see the supply numbers drop off quite significantly, especially with regard to first doses kind of dropping off almost completely in terms of what's been allocated. And the focus really is second doses. The reason I've put those as TBC is because of the announcement we've had yesterday around AstraZeneca. We know that there will be a process to make additional Pfizer doses available for local vaccination services to draw down on for those patients who would now be advised to potentially choose the Pfizer vaccine. So we will see a little bit of a shift in those allocation figures, but ultimately the national picture is that doses are constrained during April whilst the global supply chain evens out. In terms of next steps and things we're doing going forward, we're still aiming to have offered the vaccine, as I say, to all residents in JCVI groups 5 to 9 by the 15th of April. We're working across Northumberland to maximise uptake and cohort penetration in those groups, including revisiting those people who've previously refused the vaccine or those we've had trouble contacting. And we're doing that through a lot of different methods in terms of proactive communications to patients, text messages, phone calls, letters, etc., to make sure we're reaching as many people as possible. We've also got our roving vaccination service, which has been approved for mobilisation by the national team, and we're aiming to operationalise that service next week. And that's another kind of tool in our armoury that will help us maximise cohort penetration and reach some of those more isolated communities or hard to reach groups. In terms of what the rollout looks like going forward, in terms of options that are available for people on the national booking service, we're working alongside SVOC to operationalise a vaccination centre in the west of the county at Hexham Mart, and we're also identifying a number of community pharmacy sites that will be mobilised as the vaccination programme continues. So they're all options that will be available via the national booking system at the point that it reopens to first dose bookings. At the moment, because of the supply constraints, the national booking service has been closed to first dose appointments during April. Phase 2 of the vaccination programme, which is cohorts 10 to 12, so all of those people under 50. We currently haven't been given the go-ahead to start vaccinating those patients. That's primarily because JCVI are yet to give the government final advice on the way that that should be rolled out to those cohorts. I think it's fair to say after yesterday's announcement, they've been preoccupied with dealing with the AstraZeneca issue and communicating that in the most robust way and the way that will give the public the most confidence. So cohorts 10 to 12 are absolutely in our kind of thoughts going forward, but we're just not there yet, and the focus remains very clearly on cohorts 1 to 9. So in terms of the AstraZeneca advice that's emerged over the last 24 hours, I don't propose to read this one out to you in sort of verbatim, but ultimately the JCVI have issued a statement along the lines of the fact that we prevented at least 6,000 deaths so far as a result of the vaccination programme, and countless more cases of serious illness and infection from COVID-19. The reports that have come out about side effects, particularly around blood clotting, are extremely rare following a first dose with the AstraZeneca vaccine. And JCVI and MHRA together have weighed the relative balance of the benefits and risks and continue to advise that the benefits far outweigh the risks in terms of vaccination, especially for individuals over 30 years of age and those people who have underlying health conditions, which put them at higher risk of contracting COVID and getting complications. MHRA have not advised that there needs to be any age restriction in terms of the rollout of the vaccine. But what JCVI have done is kind of gone beyond that with an abundance of caution and advised that it's preferable for adults under 30 years without underlying health conditions to be offered an alternative COVID-19 vaccination. And people should be able to make an informed choice if they're in that cohort, so age 20 to 29, to receive the AstraZeneca vaccine if they want, to receive potentially earlier protection, but that'll be based on a conversation with a clinician. So in terms of how that will be operationalised and what the next steps are for the next couple of days, obviously this is still clearly a rapidly evolving situation. Guidance has been issued overnight and continues to be issued today for health professionals to understand the ramifications of this and to get key messages out to the population. It's really clear to point out that MHRA and JCVI have made it absolutely clear the balance of risk is still very much in favour of vaccination, and it's therefore critical that we implement their direction in a really balanced and operationally robust way so that we continue to deliver what is still life-saving medication for the vast majority of people. Those who have already had a first dose of AstraZeneca, whether they're age between 20 and 29 or older, should continue to be offered a second dose. That situation hasn't changed at all. So second doses should absolutely go ahead, and members of the public who've already had a first dose of AstraZeneca should absolutely be encouraged to take their second dose. There is a very limited and very clinically specific number of people for whom a second dose of AZ isn't recommended, and that's contained within the guidance that's come out overnight. And for all those individuals who are affected by that, conversations have to take place with a clinician to discuss the relative risks and benefits of continued vaccination with AZ. For all of those people aged between 20 and 29, or those with very specific clinical contraindications that suggest they shouldn't receive AZ, there'll be steps taken to offer them an alternative vaccine. So at the minute, that'll either be the Pfizer or the Moderna vaccine, and guidance on how and when and where that will be administered will follow. I think Jonathan Van Tam yesterday, when he was speaking to the media, said that we will absolutely, as an NHS, make an alternative vaccine available. It may just take a little bit longer or may involve a little bit more travel than would have done previously whilst we get the operational rollout of that sorted. So what's really clear here is that vaccination remains the safest thing for us to do and our best way out of this pandemic. And for those very small group of people that are affected, the most important thing to do is to have an informed conversation with a clinician to discuss the relative risks and benefits of vaccination with AZ. And people within that 20 to 29 age group can still choose if they want to receive the AstraZeneca vaccine. In terms of patient messaging, there'll be a lot more on this coming out over the next few days and weeks. But what I've included here on the slide is an extract from a Public Health England patient information leaflet that's been produced overnight, which just categorises for the various different groups of people, so those aged over 50, 30 to 50 and 18 to 29, the potential risks from COVID-19 versus the benefits of vaccination, and then the risk of vaccination alongside that. And you'll see in all instances, the clotting problems have been listed as an extremely rare risk and something that is highly unlikely to occur in the vast majority of the population. Just to visualise that for people, I don't know how many of you may have seen these slides yesterday, but these were shared by Jonathan Van Tam in the briefing. Effectively, these slides just weigh up the potential benefits and harms of the AstraZeneca vaccine. So on the left-hand side is the potential benefit in terms of prevented admissions to ICU from COVID-19, and on the right-hand side are the potential harms. So how many people within 100,000 could potentially get harm from the vaccine versus an admission being prevented. And you'll see for all of the age groups, with the exception of 20 to 29, the potential benefits outweigh the harms, with increasing levels of magnitude as you go up the age groups. And the reason why MHRA and JCVI have given the guidance they have for the 20 to 29-year-olds is because the balance of risk in that situation is a lot more of an even sort of balance. So that graph there is based on low exposure to COVID-19. So the situation we have in the UK sort of at the moment, really, with low incidence. As you move up the exposure risk in terms of the number of COVID cases floating around, the amount that the vaccine protects you and the amount that the benefits outweigh the risks increases significantly. So that's an example of what it would look like in a medium exposure risk situation. So where we were at kind of in February. And then for high exposure risk, if you look at where we were at the peak of the second wave, it's abundantly clear there that the vaccine is by far the safest thing for people to do, and the benefits completely outweigh the risks in terms of the right thing to do. Just jumping back a little bit before we finish to making sure we reach as many people as we can in all of the cohorts. We've set up a vaccine equity board that's a joint group that's been established between the CCG and the local authority public health team. And that board is tasked with identifying and addressing potential areas of inequity within the vaccination programme. So nationally, priorities have been set, including Black, Asian and minority ethnic groups, especially those in Black communities, those within the Gypsy Roma traveller communities, those people with learning disabilities or severe mental illness, and also socioeconomic deprivation. And within Northumberland, on our vaccine equity board, we've also been clear that we want to consider rurality and travel time as key considerations in ensuring vaccine equity. So there's a huge comms programme, as you'd imagine, alongside this at a local, regional and national level. And we're taking a lot of actions locally to ensure that we can set up roving clinics to help reach out to some of those groups. So identifying groups like the homeless and working with providers of homeless shelters, for example, to make sure we vaccinate those people. It was recently announced homeless people were in cohort 6, so they've been a priority for the Vaccine Equity Board and a group we want to reach out to as soon as we can to get them vaccinated. In terms of local messages going forward then, there's a little bit of a split in how we're advising patients within Northumberland to behave over the next couple of weeks. In the kind of southeast corner of the county, so Cramlington and Seaton Valley, Valens, Blythe and Wansbeck PCNs, we want to encourage any over 50s who haven't already taken up the offer of a vaccine in those areas to book their vaccine now through their GP. So we want people in those areas who haven't come forward to contact their GP to make an appointment if they haven't already taken up the offer. GP practices in those areas have tried to contact patients a number of times, and those that haven't come forward yet are now being encouraged to do so proactively. There is enough vaccine available for them this week and next to make sure that we can give out first doses and ensure maximum penetration of those cohorts. And then for the well up north and West Northumberland PCNs, the message is slightly different because of the larger populations we have in those PCNs. We've said that people should continue to be patient in those areas and wait for their GP to contact them. There will be enough vaccine. As I've discussed, we've got another 6,000 doses going into North Northumberland this week. So there will be enough vaccine for them to be offered an appointment by the 15th of April and people won't be missed. And just to reassure those people who are having difficulty on the national booking service, which we know is problematic, those people don't have to travel outside of the area to receive their vaccine if they would rather receive it locally. And finally, some key messages, just taking on board what's happened in the last 24 hours. I've talked about the supply constraints and that second doses for the most vulnerable are the priority for the vaccination programme for the next 4 weeks. The national booking system remains closed to new bookings at the moment throughout April. PCN sites will continue to prioritise patients accordingly, and it's really important that we maintain public confidence and understanding in the vaccination programme. And I think the overwhelming message from the last 24 hours is that the vaccines, both vaccines that we've got in circulation at the moment, both Pfizer and AstraZeneca and the Moderna vaccine that's coming online, are safe and effective. And it's absolutely important that we maintain public confidence in that. And I think the steps that have been taken and the guidance that's been issued by MHRA and JCVI are as a result of the fantastic surveillance and monitoring programmes that we've got in this country. And really being put out there with an abundance of caution, rather than flagging up a risk that's likely to affect lots of people. So the risks here are extremely rare, and we want to emphasise that the vaccines are safe and effective. And the number one key message, which we started the presentation with and we always finish with, is that the number one key message as we continue through the programme is for people to wait their turn. Please be patient, nobody will be missed, and we will get around everybody absolutely as quickly as we can. So I know that was a huge amount of information, so I'll pause there for any questions that anybody may have.
Right, I think we need a breath. Okay, I can see Susan Dungworth. There seems to be an echo on the line. Can anybody mute who's whatever? Thank you. I've got one question to kick off. I can see Jeff Watson. I don't know who's going to answer it. On the way in, there seems to be a spike at the Novotel at the Newcastle airport with 30 or 40 cases. That's quite close to the border of this county. Can anyone update on that? And then we'll get into the questions.
Yeah, so Richard, it's Liz. So we have got, I know Newcastle have got a an outbreak in a particular setting. I don't have the details, but it's that outbreak which is contributing to the blipping cases in Newcastle, and they are managing that in the same way as we manage every other outbreak that we come across.
Right. Okay. Keep an eye. Right, Jeffrey Watson.
Yeah, I've had a query, the first one I've had so far, about the second doses. What exactly, how long is it from the first to the second dose? And is it a critical period? I've had a query from somebody who reckons that they've gone through their 12 weeks and not been contacted yet. I'm not sure about this. I've asked them to check that they've correctly got the date and counted the dates. But is it critical, Liz? Is it, and what's the attitude about it? Second doses.
So I think the guidance is that people have that second dose anytime between 3 weeks and up to 12 weeks. Obviously the timing between the first and second dose was extended on the advice of JCVI, so that we actually got more population benefit from the vaccination programme. I think probably Richard's in a better position to explain what the recall process is for individuals to come back and have that second vaccine.
Yeah, thanks, Liz. So in terms of the recall, there's two different options, I suppose, depending on how people booked their vaccination. If they booked via the National Booking Service, they will have booked their second dose appointment at the same time as their first dose. So that will be kind of set in stone. Those people that received their vaccine locally via primary care network sites, they will be called in to receive their second dose once deliveries have been confirmed. So second dose allocations get confirmed on a rolling basis. And we actually get second dose deliveries sent out at 11 weeks. So they get sent out 77 days after the first doses are sent out, in order that we can vaccinate people with their second dose during their 12th week. We are aware of some individuals who've gone beyond the 12-week threshold for a number of reasons, potentially because they had COVID symptoms, or they were ill in hospital, or they missed an appointment. It's not critical in the sense that if you go beyond the 12 weeks, you have to start all over again and have another first dose. We can keep giving the vaccine out, beyond that date and bring people in for their second dose. Guidance is continuing to emerge as well on the long-term benefits from the first and second doses. But in answer to your question, Jeffrey, it's not critical, and we can bring people in at 13, 14, 15 weeks if we need to, if they've missed their appointment. If anyone does feel that they've been missed for their second dose, though, they should get in touch with their GP practice to follow that up if they've gone beyond the 12 weeks. But we've got a lot of confidence in the mechanisms that GP practices have got to bring patients back in.
Okay, I'll go to David Thompson. I hate saying these words, David, you're on mute.
I always am, Richard. Between January and March of this year, Healthwatch Northumberland received quite a few comments about the vaccine programme, and not surprisingly really, and they have written a report on the findings, as we are obliged to do, really, and a copy of that report has been sent to the CCG, and I know there has been a conversation between Rachel Mitchison and Gary Nugent about the findings of that report, which will not be published until after PERDA, etc. But I am assured that the messages which were received from the public independently, we didn't ask for comments, they contacted Healthwatch Northumberland, but those independent comments from the people have been passed to the CCG, and I'm sure that the messages from the public will have been taken on board and action will have been taken as a result of that.
Okay, thank you. I have got Kath McAvoy, Carr, then Jane Lothian.
Thanks, Richard. Just very quickly, I know that within the presentation, Richard, you state that all those who've had the AstraZeneca who are less than 30 should continue to get their second dose. What will happen, and I'm just thinking about in terms of workforce on health and social care, we have a high proportion of that workforce who will be under 30. What happens if they don't want the second AstraZeneca dose? Will they have to start their process again, potentially?
So that's something that's still yet to emerge in terms of specific guidance on that, Kath. I think the overwhelming message from JCVI and MHRA is that if you didn't experience side effects the first time round, in terms of the blood clotting, you're absolutely encouraged to get the second dose, and we'd encourage all of those patients who are under 30 and due a second dose to have a conversation with a clinician on the relevant and relative risks and benefits. And I think there's guidance yet to emerge on what happens if those people want to decline the second dose and what their options are.
Great, thank you.
I think that will be a problem that will come down the line if it emerges.
Yeah, I think that a high proportion of our health and social care workforce are very young, and I think that might cause some challenges going forward. But so the quicker the guidance, the better, really, I suppose.
Yeah.
Stating the obvious.
Jane.
Yes, forgive me if there's background noise. I'm actually in a car. Just to add to the only thing I wanted to add to what Richard has said is that and certainly from the regional vaccination board, there's an issue that has been raised in response to the issue about people going over 12 weeks, that the mechanisms for people who may have moved area or even moved, if they've moved within Northumberland even, so that they may be registered with a different doctor, or university students, people who, it is quite possible that they may not, may not have been contactable, whatever. So I think on a case-by-case basis, these people need to just contact their registered doctor. I think, Richard, you'd agree with that, wouldn't you? That's the only addition, is people who may have moved about in the country.
Okay, noted. Right, Siobhan?
Hi, just a quick one from me, Chair, to say that despite these glitches that we've got at the minute, this is one of the most phenomenal programmes our system has ever delivered, and I do want to thank everyone who's involved in it, because the numbers of vaccinations in our county is just really incredible. So thank you all for the work.
Wouldn't be without Susan. Susan.
Thanks, Richard. It's just a couple of observations on things that people have said already. I think it is really important that we are thinking now about the implications of yesterday's announcement, particularly in relation to staff who work within the care or the health sector, because I am sure there will be a kickback in terms of people not wanting to go with the AstraZeneca. So, I know it's down the line, but let's try and have a plan now and anticipate that rather than then dealing with it. And the other people who get missed are older people who end up in hospital, miss their second vaccination, end up in a care home, different doctors. And again, it's about making sure those systems are much smoother. than I think they are generally. That you know, I have a case of somebody who was due their second vaccination on the 11th week, and 4 weeks later is still waiting for it. He ended up in hospital. He then ended up in a residential care home, 2 different hospitals and then a care home. And it just like seems, you know, this whole thing about you have to pass to a different GP if you're in a different area, whereas this almost needs to be above that. Because what you're doing as well is, if you're not giving those older vulnerable people that second vaccination, you're risking again hospitals and residential homes not being safe when we're just about getting there. So I think both care workers and residents, I think it's an issue for both sides. But as Siobhan said, you know, it is a massive operation, and all credit to the people who've delivered it so well. But let's try and be upstream rather than downstream in identifying problems to come. Thank you.
Richard?
Just to say that individual case, Councillor Dunworth, we're more than happy to investigate that. If you want to pass the details across to either myself or Rachel, we'll investigate that and see what's happened there. On the whole, uptake rates of second doses have been really good so far, and GPs have got absolutely robust systems to identify anyone that maybe has slipped through the net for their second dose for whatever reason. So that's something we're definitely focusing on. And in terms of the proactivity, absolutely, we're considering as many of those implications as we can at the moment, including, you know, when we roll out to cohorts 10 to 12, what the views of the younger population will be. And there'll be a huge comms campaign, I'm sure, at a national level, but also locally. We'll do whatever we can to get the key messages out. I think the key message for those members of staff in that 20 to 29 cohort is going to be around positioning the risk from the AstraZeneca vaccine alongside some of the other risks that we encounter on a day-to-day basis, that people expose themselves to without potentially, you know, giving it any consideration. Things like getting in the car and going on a long journey, or even being kind of, you know, attacked and mugged in the street, those sorts of things. There was some really interesting articles on the BBC about that, that kind of set that risk into context. And I think that's something that'll be really important in terms of our messaging from the CCG, GPs and public health going forward, to make sure people understand the risk in the context of, as I say, other risks that we encounter in daily life and with other medications that people take without a hesitation. Yeah, that's going to be vital going forward.
David?
All I would say to that is that unfortunately this feeds into that whole anti-vax narrative about they don't tell us the truth and they do that. So whilst all that is totally rational, and we get that, we still have to accept that there's going to be that kickback from it. You know, more women get thrombosis from taking the contraceptive pill and have been taking it for years. So, you know, I get that, you get that, but it feeds into that narrative, doesn't it?
David?
Thank you. Just very quickly, I just recall there a mention about the lateral flow tests being available twice a week to the whole community. How do people access them? How do they get them? And has there been a strong communication message just to make sure people know they are available and how they can get them?
Who's taking this?
Yeah, so we are, if we haven't done some comms around that, we will be. I think we're still, since the announcement was made, we're just sort of waiting to get some further information about what that actually looks like. And of course, some of those access routes are still in development. So community pharmacy, for instance, is one of the routes where people will be able to go in and collect collect tests to do at home. But they only got the service specification last week, so it's going to be a little bit of time before they'll be up and running. But certainly, I'm sure Anne will be able to talk about it more. But I think we need to make it clear how people can access lateral flow tests, and of course people are accessing them already. We've got employers who are testing. We're testing our own workforce. Families of school-aged children are accessing tests. You can order them at home, order them online for delivery at home. You can collect them from the PCR testing site. So there are already quite a few mechanisms to access them. But yeah, I agree. We need to just keep pushing the comms out on that.
Thank you.
Right, Susan, is that a historic hand? Yeah. Right, I have no more hands that I can. Yes, someone's just appeared. Hang on, who's that? Oh, it's David. I cannot see anybody unless somebody is unseen. All I would really like to say is, because I know that I take this AstraZeneca as a bit of a slight blip, but it will feed the monsters who are out there. And the next item out there is comms, and we'll come to that. But I just have a fear that we all see the emails and the stuff on Facebook that is entirely true, as you all know. So I fear for that. However, as a heartfelt thanks to all of the people who have made this work, I can only say one massive thank you. If we go back to the dark days of March last year, when we all got locked down for the first time, it was all a bit strange. And we all thought every time we coughed, we thought we were going to go somewhere we didn't want to be. I'm very, very proud of the way this has been handled. There's no other words can put it that way. Yes, there's going to be a problem here or whatever there, but everybody is really, really pleased that we are ahead of Europe. We're ahead of the world. And I think that, I can't say any more thanks to the people that are involved in this. And I know we are on the periphery and the whatever of it all. Some of us who are members are trying to appease people, but all I can say is thank you. And with that, I'll move on to comms, which is 6A, not on your agenda, and I'm going to go to Anne Bridges. Thank you.
Thank you, Chair. And if I could just echo your pride and gratitude in terms of the phenomenal effort that's gone in. I guess since we last met on the 29th of March, much has changed, and that stay-at-home instruction is now lifted, and we're now gearing up from a communications perspective for further easing of restrictions on the 12th of April. We've continued to amplify the national message around hands, face, space, and of course fresh air now. What the COVID symptoms are, but also that 1 in 3 don't have symptoms, as well as encouraging people to continue to do what's necessary, obviously, to keep themselves and others safe. As Liz mentioned, the guidance for the clinically extremely vulnerable ceased on the 1st of April, and we've been supporting those residents who've been shielding through our fantastic Communities Together team and our community and volunteer networks as well, who are doing a phenomenal job. And for some of those people, they've been shielding for more than a year, as Liz mentioned, and that can be really challenging in terms of venturing out again. Come Monday, obviously, we'll continue to support our schools to resume after the Easter break, with the advice to continue to wear face coverings in school for secondary age children, certainly until the next milestone of the government's roadmap on the 12th of May. Again, as mentioned previously and has been raised here, the regular testing is to become very much part of our everyday lives, and announcements are being made on these all the time, daily even, and we're working hard to make it clear as possible as to who needs to do what and when. We have been sharing messages forever on that, but we're updating them and updating our website just as quickly as we can. But clearly, as David said, that's now been extended to all, and we're working to make those testing kits available across all our communities once we're clearer around what those distribution methods are. Liz mentioned the mobile distribution testing facilities have been trialled over the last week or so, and we've had some in different areas, Ellington, the Manor Walks, and up in Rothbury, where it worked really well. So we're looking at those and the other distribution sites as well. Reporting of test results is a bit of a challenge in terms of percentage of people who are reporting those, particularly if you've got a negative test. I'm actively doing that just now. I've got 2 secondary school age kids, and we're all doing that at the minute. But the percentage of people reporting their testing results is low, so we're actively encouraging people to do that, our residents and our businesses to record them. As ever, we're supporting our partners in the CCG with the messaging around the vaccine rollout and the ongoing through the various cohorts and that second dose priority message. And obviously that around being patient, and those different messages, Richard, were really helpful in terms of the different areas across the county. So we'll support you with that messaging as well. Those wraparound groups that Liz mentioned before, we're continuing to support them around their communications and engagement activity, with a particular focus around the businesses as they start to reopen on the coming Monday. For the hospitality businesses, we've developed a business pack across the region with our colleagues in public protection, and that has been rolled out as we speak. It will be available on our website and across the Beat COVID hub as well. There's really some guidance on how they open safely and continue to operate in a safe way. Our community champions, we're continuing to recruit those, but we've got another big push on those to further develop it, to attract key trusted voices in our communities, and that's going to become really important, particularly around some of those vaccine equity issues that we talked about, and that public confidence as well. The regional campaign, Beat COVID NE, is being extended, and over the next 5-6 months, we'll be focusing on obviously opening our economy and our society safely, but supporting the vaccine rollout, and encouraging people to adhere to the kind of new normals, as we call them, really. From Monday, that messaging around that regional campaign will focus on the kind of staying outdoors message, which chimes with the national campaign, but it'll have local messaging in there. And we know, as Liz mentioned, there's challenges around self-isolation to support self-test and trace, and messaging is getting developed around that. Part of that regional work for Beat COVID is around vaccine hesitancy, and we're developing targeted communications across this that include the kind of harder to reach groups. And in Northumberland, we've got specific issues around those ourselves, and other areas it might be more BAME, but that'll be really targeted communications. But obviously we need to take account of the announcements around the side effects, the different age groups, and the JCVI guidance to maintain that public confidence around the vaccine. We're obviously acutely aware of the pressure on our communities as the tourism sector starts to reopen, and we're working with partners across the county and neighbouring areas to agree a communication strategy on that based on the roadmap. It's fair to say spring and summer this year are likely to be very busy in terms of domestic tourism. I mean, it's not clear yet whether people will be able to travel abroad this summer, but there will still be restrictions in place. But we are expecting domestic tourism to have a real boom this year. So that communications campaign that I was talking about, the kind of core premise of that is that it's not around attracting people. We know from the kind of strong bookings that they're already on their way, they're coming. But it's about whilst they're here, welcoming them, but encouraging them to treat Northumberland well whilst they're here, to respect, protect and enjoy our county in line with the Countryside Code, whilst reassuring our residents and maximising the economic benefits for the visitor season. Key to this is our tourism partners and the sector buying into this campaign. We're going to open that campaign by creating a toolkit for all our tourism businesses, so that help us amplify and reinforce that messaging. So we're working with our partners such as Visit Northumberland, Northumbria Police, National Parks, Kielder, Hadrian's Wall, our areas of outstanding natural beauty, etc., who can all adopt and use this as well. Part of that's really important, that we have ability to share real-time or dynamic information. So when there are issues in particular areas, we can use our partners and our businesses to share that really quickly. which is why this kind of multi-partner approach is really, really important. So, for example, last summer we had big issues in a lot of our coastal areas, which members will know about. And it's about telling people really quickly that there are issues in that area, whether that be a 2-hour wait to get into an XD car park if you're going there, but encourage them to go elsewhere as well, so we get a more equitable spread of our visitors across the piece. And if you can understand, the tourism businesses are really important to that, because if they've got people staying in their hotel, their accommodation, self-let accommodation, if it's important that they can say to the visitors that, you know, we know that Bamburgh's really busy today. We've seen some messaging. Why don't you try and head over at Hadrian's Wall or whatever it is? So that dynamic information is really important. With that in mind, we've already deployed some digital road signage, which you may have seen across key beauty spots in coastal areas, and we can update them really quickly. So that helps our real-time and dynamic information. We had them deployed over the Easter weekend, and obviously they become more important as we move through the spring and summer. As part of this, in terms of our visitor management plan, albeit not comms related, the Council's introducing a number of measures to reduce any negative impacts due to the influx of visitors. So including things like more bins and increased waste collections in popular destinations, developing extra car parking, increasing enforcement for illegal parking, traffic management, increased toilet cleansing, that type of thing. And that'll all help us manage that kind of influx of visitors. So that's it from me. I know that was quite a lot to take in. Happy to take any questions.
Right. I mean, we've had a lot to take in today. Right. David.
Yes, thank you. Can I just go back to the lateral flow tests, if I may, because if they are to be made publicly available to everyone, and if there is a mass take-up of these LSR tests, it then begs the question, what will happen to those people who via this test is positive? Because from what I gather, these lateral flow tests are not particularly reliable. So if someone takes a test and deems themselves to be positive, what will happen next? What will they do? And I think it was mentioned that this will be followed by a PCR test.
I think Liz is going to come in.
Is there sufficient capacity to handle that potential and to handle it quickly? Because the implications of this are quite limitless in some ways.
Right, David, I'm going to go to Liz, who's going to answer.
So I think probably the first thing to remember is that the lateral flow device tests are for people who don't have symptoms. Yeah. And the data that we've got at the moment suggests, I think, that something like 1 in 1,000 of those tests are coming back as positive. So the idea then is that if you test positive with your lateral flow device, then the advice is that you then get yourself tested using PCR, and as long as you have that test within 2 days of your positive lateral flow device test, then whatever the result of that PCR test will then dictate whether you self-isolate or not. So if you have a positive lateral flow device test, you then go on and have a PCR test. If that test comes back as negative, then your requirement to self-isolate is rescinded. But if you go and have a test and it comes back as positive, then you're required to self-isolate for the 10-day period.
And so okay. that assumes the capacity is there to handle all of this.
Yeah, but to be honest, at the moment, because the number of cases that we're getting through is relatively low, there is plenty of capacity. I mean, I was looking at the testing rates in our PCR, or testing numbers in our PCR sites, so the local testing sites, yesterday, and we're literally getting 14, 15 people coming through a day. So there is plenty of capacity in the system at the moment.
Okay, thank you.
Right, any more? I think the challenges are still here. the holiday season or weather might get a bit better. So, you know, the challenges of car parks and toilets is still all with us. Let's hope that we can move forward and not go back to where we've been. So I'd like to move. Oh, Susan, got you.
Sorry, I just came in at the end there because she gave me a bit of a cue. And it's what Anne was saying about visitors to Northumberland. We are facing incredible pressures as communities along the coastal strip in particular, around day visitors, which is something that Northumberland hasn't particularly focused on in the past. It's been more around people coming and staying. And I'm concerned that we're not communicating with those residents very clearly. So we put up some flashing signs telling people if they're coming to Northumberland to take their litter home, which they generally ignore. But the residents who live in those communities feel as if they're not being listened to, and as if the council is not doing anything to support them and protect them. Now, I know that isn't true, because I personally am doing a huge amount to try and do that, but I know other people are as well. But as a council, we are not communicating with them. We're not saying, you know, we understand there's an issue and we're working on something to solve it. And I think what Richard says is right. You know, this is going to get worse. It's not going to get any better this summer. And we've been saved a bit this Easter by the weather, thank goodness. But, you know, it is, I have never known anything like it. And we need to communicate. So our communication shouldn't be just to those people coming in, but it should be about reassurance, and it should be about listening to the residents who live here.
Anne? Do you want to come in?
Yeah, absolutely. Yeah, I agree with you, and that actually is one of it was number one objective in terms of reassurance to our own residents in terms of what we are doing. So I completely take that on board, and we'll make sure that we address that. But it is part of the campaign going forward. It's a really important point.
Yes, I think we have to just wait and see and pray for bad weather. So think of the poor little lambs on farms. Anyway, right, I'll move on. I have no further hands I can see. Item 7, Children's Young People Joint Commissioning Update. Who's taking this one? Is this Rachel?
So Richard, I'll just say a little bit just to put some context in there, and then Rachel's got a presentation that she's going to run through. So okay. I'm hoping that members will remember that we had a send, that we had a send Ofsted and CQC inspection in 2018, and one of the areas that we were asked to focus on was our joint commissioning process. It is an area that a significant number of local areas struggle to be able to demonstrate the effective joint commissioning arrangements that are in place, and we've done an awful lot of work around our joint commissioning arrangements and can demonstrate some significant progress that has been made around this particular area. I think what we would say though is we had a peer review earlier in the year which demonstrated that although we have made some progress, we've still got some way to go before we can showcase a completely joined up commissioning process. But I think I know that it's highly likely that we will be revisited by CQC and Ofsted this year. So we have a real focus and a real drive on trying to ensure the messaging around joint commissioning is strong. So I'll let Rachel demonstrate that by the presentation.
Thank you, Kath. Let's get the slides. Brilliant. Okay, hopefully. Can we go to the next slide? Oh no. Can we get to the next slide there? Sorry, I don't know. Seem to be able to move the slides on.
Yeah, see something now.
Right, so sorry. So obviously you've got a paper which has got the detail, and I just thought I'd pull out some of the facts. So as Kath said, from a strategic point of view, we had our inspection in 2018, and we had the peer review, which still suggested we could improve on how we articulate our joint commissioning, although it did absolutely acknowledge the progress that we've made, which is what I'm going to go through now today. So the next slide just shows the joint commissioning cycle. Thanks, Richard. Just shows the joint commissioning cycle of what we're trying to do and what we mean by that, because I think sometimes there is confusion about what this actual title is. So it is really about understanding the children that we've got and make sure we have appropriate governance around how we deal with those children and that they get the services that they require. We have a joint strategic needs assessment, and together we have that shared understanding of that population's needs, and we plan together and make sure we share our priorities across those groups, and make sure we are all aware of each other's plans and have joint plans around how we prioritise. And then what we actually do around that might be around how we collaborate differently, join together, integrate and align our services together, which is what we're trying to focus. Next slide, Richard, please. So we have a number of slides. Hang on, sorry about this.
Got it.
Great, thanks. So we have a number of shared roles, which I think has really helped us going forward with regard to how we do our joint commissioning. So myself has a shared role across the CCG and the council. We have a head of strategy in the council, who is also our designated clinical officer for the CCG, which is Sam Barron, which works very well. And we've also recently, within the last year, have a children and young persons operational commissioner. So we've almost now got a team of people that work across, which is really helping as we develop our approach. Last year I did a stock take for the next slide, please, Richard, just reviewing the meetings we had, the governance, making sure we did have the right understanding, the right plans, and then looking to see how we can be more robust in how we go forward with some of our committees with regard to individual children, as well as mental health services, and equally, we've been able to review some of what we've done with regard to COVID and how that has really changed how children have been able to access our services from a really positive perspective, and I'll come on to that as well. So on the next slide, it just shows our roadmap. Seeing as everyone else has got a roadmap, we've got one too, and we've focused in now on sort of 3 key areas for our joint commissioning. One is around better understanding of those individual, very complex children who often need services that are outside, in addition to what we already commission and more bespoke to their needs. The next one is around getting earlier identification of these children. So we know the older children get, and that can be quite a difficult time when it comes at a crisis, whereas if we can identify these children earlier and put services in place when situations aren't quite as critical, we get much better outcomes from our children. So making sure that we can do that better, and then we can start to plan ahead for some of those children for when they do need maybe the services as they reach transition and into adulthood. And thirdly, just looking at the services that we do commission and making sure that we've got good access to those services, that they have got the right skill mix, and that those services equally operate across health and social care in an integrated way. So that's our roadmap, and I'll just go through each one of those in a little bit of detail just for you, just so you know. So on the next slide, it's just around the individual cases. So we have totally reviewed how we deal with our individual cases. We have regular meetings across health and social care, looking at very clear criteria around the continuing care needs of children and making sure that their needs are met. And I think equally that joint working has helped us and helped the council and the health services identify the right children as we work together to work through their eligibility. That is working really well. We've got some key CCG roles around learning disabilities and mental health coordinators, which again straddle both services, and our head of complex care commissioning is really working much more closely now with the senior managers in the council around those effective placements and making sure we are really looking at all options that are available rather than working individually, and we're getting some really good results now and some good relationships and trust building up between those services, so a good foundation to build on going forward. The next slide is really around the early identification, and we've seen some really fantastic support results now from our Trailblazer, which I think has been presented here before, from our additional mental health support teams, and much better access now to our 4-week wait pilot into mental health services. We've introduced the BU website link for children and young people with emotional health and wellbeing problems, and it's been well accessed. And through COVID, we really commissioned very quickly and rapidly some online support to children and young people using Couth as a platform, and equally education staff using Quell, which again we've jointly commissioned across and has been really successful throughout COVID as we needed those supports to be available online. There's some co-location of workers to help work in more integrated ways with mental health workers and the early help team, and introduction of community wellbeing practitioners in early help and social care is a really innovative model, and we're looking at the co-funding of Sendias, which is an information platform for parents to access, just making sure that that information is all up to date, and we're working together with that, which is really good. The third one on the next slide is around how we get our services to work in a more integrated way, and to look at the sort of skill mix within some of those services. And you might be able to see that triangle, which is quite small, but this is a way in which allied health professional services, so OT, speech therapy, physio, have triaged their work and provided a digital solution to be able to see children throughout COVID, and that's been really well received by schools, as therapists have been able to watch a child in a classroom environment over a screen, which is maybe less intrusive than actually being there in person, as well as supporting sort of MDT working. As we know, we can get a number of people very quickly on a call to make sure children's cases are discussed and information is shared, and that has been really positive. And equally, some of the virtual appointments for parents at home when they haven't had to then bring their children out to wait in clinic environments, it has been also helpful for therapists to see children in their own environments, again in that less intrusive way, so it's been really useful. We've looked at setting up some core principles, which I'll share shortly, but really engagement in this is key to success, and engagement has been a significant challenge with regard to our parent carer forum and the general public just with COVID, but something we need to absolutely pick up, as well as being able to engage with our provider services, who have clearly been very busy dealing with COVID. Next slide. Just shows those sort of core principles that we are wanting to improve our services around that shared working, personalised agenda, being able to use digital in a different way, maybe having some sort of drop-in, having more choice of appointments. So these will be things that we would like to build any changes around. And then on the next slide, just around our key priorities, we want to have these as sort of groups to incorporate our core principles. So there is lots of work around workforce and workforce planning and development, how we manage to integrate services, engagement with schools and young people, ensuring equity and clear access, and that co-production, which is really invaluable with parents and carers, which we need to do throughout the development, which hopefully will get easier as our lockdown restrictions ease. And then on the next slide, just from a next steps perspective, we want to do some engagement with parents and carers around what we're going to be doing, certainly with the services going forward. understand the challenges and that have faced our services through COVID, and have a bit more opportunity to engage with our provider services, and again gain an agreement around those priority areas so that we're all working on the same areas, and ensure key professionals are very much represented on a new partnership board that we're setting up around autism. So that is another thing that we are jointly developing, and being able to then look at how we can support children and young people with autism. So finally, just in conclusion, you know, the full impact of COVID is being understood as we slowly recover. It's been really difficult, as you all know, and very challenging, and has, you know, created some changes which are positive, which we want to keep. But equally, there is potential new demand, particularly around mental health services, that we absolutely need to make sure our services are able to meet and target. Our key 3 priorities of understanding our complex children, early identification, and the principles embedding our new services is very much our direction of travel and what we will keep going. We've got some really good guidance from the Centre peer review that we did, so that gives us some next steps that we need to follow with regard to joint commissioning, and we want to support this further development of children outcome data across the system in order to feed into the strategic planning and joint commissioning going forward, make sure our local provision is sufficient for the needs of our population. So that's really all I wanted to say. Thank you very much for listening. Happy to take any questions.
Any questions? If we can remove the, yeah, that's better. Right, anybody, any questions? I think that's been a thorough report, Rachel. I've got nobody, so I don't know if that's good or bad. But
I'm going to say that's good. I hope that's good.
Yeah, it's progress. Right, of a description. Right, I have not seen any questions, so thank you, Rachel, for that.
No problem.
I'll move on to item 8, which is the Health and Wellbeing Forward Plan. It's a historical document, as you can see. It goes back the term. I will come back to that. There's nothing for the next meeting, which I'll touch on in the next minute, because it's a new council. Right, I'll go on. Anything on the forward plan? I don't imagine there will be. I'll go on to item 9, which is urgent business. I have none. As you can see in here on your 10, the date of the next meeting, there will be no meeting in May. It sort of falls between the end of the election process and the formation of a whoever, whatever in May. It would be unfair to have a meeting because I think we'll all be doing something else. So the next meeting on this paper is the 10th of June. So with that, I can't see any hands, but I would like to thank everybody. I would like to thank especially Liz Morgan, who has guided us of late, and I know it will have, everybody has suffered under something. Liz, you've made our suffering less. So the way we've had to go through all these briefings, and I'll come back to that on a, you know, whether we continue with the briefings. I'm working on that we have. And I'd just like to thank everybody for the last 4 years. I mean, here we are. It's 11:30. I'm 30 minutes over, but it's been a very, very interesting meeting. I like to put pride on keeping meetings brisk. So it's me, and I'd like to thank Andrea for being the committee clerk on here, but all of you for making a positive contribution. I don't think we've ever really fallen out politically on this one. And I think all I can say is for everybody that comes to this meeting, I hope and I think we've made it at times jovial, but it's a serious committee, and I think we would like to continue in that vein. So I've got nothing further to say other than signing off as the chairman of the Health and Wellbeing Board, because whatever happens, I don't know, and I haven't a clue who will be in this chair in June. So thank you, all of you, for making this a very, very pleasant committee to chair. So thank you very much.
Well said,
Okay.
Richard. Well